Well, first of all, let me say what a pleasure it is to see all your smiling faces this early in the morning on the second day of the conference. As you just heard, this session this morning is really going to have a theme, and the theme will come back to drugs and genomics. I was just talking to Dan Roden backstage here. He'll be ending the session with, I'm sure, a stimulating discussion of how he's mining electronic medical records for novel information which will relate to drug response phenotypes. We have Lon Cardon here from GSK who will be discussing how genomics is helping the pharmaceutical industry develop new drugs, and Larry Lesko, who has a long career in the FDA with regard to regulatory science. So you see that there's a theme here. So I'm going to start off, but frankly, pay attention to what's going to come after, because they're the ones who really know what's going on. And what I'm talking about, as you see on this first slide, is pharmacogenomics, the issue of genomics and drug response. And we have the learning objectives, but because I spend all my time teaching graduate students and medical students, there will be no doubt at the end of this what the objectives are, because I'll tell you over and over again. In fact, one of my former medical students said he was going to hide in the corner because he was afraid I might ask him a question during this lecture, as I do usually. So we're going to have a few introductory comments, and then we're going to talk about the kind of stuff that we heard on Sunday in here during the pre-conference course, and that we heard in the session on drug-gene pairs yesterday in the afternoon. That is, we'll talk about pharmacogenetics, the one gene at a time, one drug at a time approach. Then we move on to, and that we're already implementing. That's already going into the electronic medical record at Vanderbilt, where Dan Roden comes from, here and in your institutions. We'll then move on to pharmacogenomics, because I think people don't quite understand that we're well beyond one gene at a time, and we're now scanning across the genome, and we're not looking at those boring drug metabolizing enzyme genes that I teach about in the medical school and that the students immediately forget about, but we're scanning the entire genome to try and find genes, generally genes that relate to pharmacodynamics, the mechanism of drug response, which means we can identify new drug targets. And then I'm going down to that word at the bottom that most of you have probably never seen before, pharmaco-omics. It was coined by my colleague, Dr. Liwei Wang, who is a co-PI of our pharmacogenomics research network here. That is, we're well beyond just using genomics. We're going to take as many omics as we can, put them together, and try and see what that teaches us about drug response. And then there'll be a few concluding comments. Now, everybody in this room knows, because you were exposed to it all day yesterday, that pharmacogenomics and pharmaco-omics are critical components of personalized or individualized medicine. Why do we want to know this? Because everyone who writes a prescription for a patient or is dealing with a patient in any way is dealing with drugs. And at one end of the spectrum, because the drugs we use in the 21st century are not the placebos that the general practitioner who lived next door to me in the little town in southern Kansas where I grew up used to prescribe. They can really do stuff, but they can do very good things or very bad things. So number one, we want to avoid adverse drug reactions. We use the drugs because they work, so we want to maximize drug efficacy, and that bottom line gives the chief financial officers of Big Pharma, I'm sorry, Lon, but I think this is true, the heebie-jeebies, because it says we can potentially select responsive patients at the front end, which may mean that the era of the blockbuster drug will be fading away. Now, this is a science, and underlying everything we do is science, so what we want to do is link the genomics or the metabolomics or the proteomics to variation in the drug response phenotypes I've just shown you. We want to understand the underlying mechanism, and we want to translate that link at the end into increased understanding, better diagnosis, better treatment, and ultimately prevention of disease. And I'll show you one example of that, where we're using drugs to prevent a major cancer. So here's the evolution of this field as I've seen it, and I've lived through most of it. That is, we began with the one gene at a time, whether it's a cytochrome P450 or a transporter or some other drug metabolizing enzyme. We're now clearly into the era where that is so last century, and we're looking across the entire genome, and we're moving on to begin to integrate all of these omics techniques to teach us about drug response, and I'll show you an example of that. I'm going to use 3 diseases, basically. 3 totally different diseases, because the principles apply to whatever your favorite disease happens to be. So we'll begin with the #1 cancer of kids, acute lymphoblastic leukemia of childhood. We'll move on to the #1 invasive cancer of women, breast cancer, and we'll then go to the #1 psychiatric disease worldwide, major depressive disorder. So with that as background, let's start at what we were talking about yesterday and in the drug-gene pairs, the one gene at a time thing that most people think of when they think of pharmacogenetics or pharmacogenomics. But I think we need to put this in context, and this will bring back fond memories to some of you. I have on the right here, Goodman and Gilman's 11th edition. Now, I just went out, the 12th edition's out. I went and bought it. I was going to bring it over here from the Ganda building, but I've gotten a hernia carrying it over if I had, so I didn't do that. But on your left, you see the first edition of Goodman and Gilman, 1941, and the rumors among the Mayo medical students that that's the one I used when I was in medical school are somewhat exaggerated. And I put them up here to make a point. That 1941 book's about the same size as the 11th edition of Goodman and Gilman, and there's nothing in it. There are no antibiotics, no antidepressants, no antipsychotics, no antihypertensives, no nothing, basically. Sulfa drugs were invented in 1939, and they weren't even in it. So, folks, to quote that poet from Hibbing, Minnesota, the times, they are a-changing. This all happened during the lifetime of some of the older people in this room. So it's amazing, but that means we have powerful tools, and that means we should use those tools appropriately. So here, what I did here was just pick some drug-gene pairs that the FDA has held public hearings, relabeling, warnings, black box warnings for, and it's not entirely by accident that I put thiopurines and TPMT at the top, because every story I'm going to tell you is a Mayo Clinic story, so allow me to be provincial. And the TPMT genetic variation was discovered in my laboratory at Mayo about 1980. Yesterday, John Black yelled at me from a podium in the drug gene pair thing, "How long ago was it, Dick?" And I was hesitant to say, because it's actually well over 30 years ago that this came up. So this is a set of drugs that were developed at the Old Burroughs Wellcome Company by George Hitchings and Gertrude Elion, and this shows you the kind of impact that drugs can have. You're looking at Kaplan-Meier curves. This is the St. Jude experience, where we're looking at childhood leukemia, and at the bottom is the Paleolithic era when I was in medical school at the University of Kansas, and if we saw one of these kids, and if the diagnosis was right, that child would be dead in 1 or 2 years. My daughter's a pediatrician at Wake Forest, and she sees these kids, and if she can't cure them, she's beside herself. Think what I just said. That's not radiation therapy, that's not surgery, it's entirely drug therapy. This is a triumph of modern medicine. I don't think the public is aware of it. Now, what made that possible? One of those drugs that's in the drug cocktail that my daughter uses to treat these kids is 6-mercaptopurine. You can see at the top here that what George Hitchings and Gertrude Elion did, they said if God wanted us to have a sulfur in our purines that are in our DNA, he or she would have given it to us there, and so we'll stick a sulfur in, it'll screw up DNA and kill rapidly dividing cells, and it worked. Now you'll notice, and if I can figure out you'll notice this thing called thiopurine methyltransferase. It was known that the way the body metabolizes these drugs is by xanthine oxidase, or S-methylation. That was discovered by a man named Remy, who was at Wake Forest, and I sat in he's 80-some years old, I sat in his living room and asked him how he discovered this in rats and mice, and he said, "Is anybody interested in that stuff anymore?" He had no idea that we were actually using this as a clinical test. So what we asked those 30 years ago is, okay, is it possible there are genetic variations in some of these kids so they can't metabolize these drugs? Because if you looked at the PDR, and I know the PDR is all online now, from 1980 it said about 1 in 300 kids, when you treat them with these drugs, they'll have profound myelosuppression, which can be fatal. Now, what you're seeing here is a frequency distribution histogram. So what we did was go over to the Mayo Clinic blood bank, get blood samples from 300 randomly selected blood donors. Now, there's an important point here, folks. What were their names? I'm not revealing anything to tell you that their names were Olsen, Jensen, Svensson, Anderson. They were all Scandinavian Americans, because had I done this study, not at the Mayo Clinic, but at Fudan Medical School in Shanghai, I'd have never seen this, because the variant I'm telling you about has never been seen in East Asia. Not in Japan, not in China, not in Korea, no place. So what you see here is a trimodal frequency distribution, and right down at your lower left, you see this one bar that has 0 enzyme activity, and that lady still lives here in town, and when I see her on the street, she'll stop me and ask me how her enzyme is doing. I mean, Rochester is a weird town. I'll be standing in line at a movie theater, and somebody will come up and say, "Hey, doc, how's the pharmacogenomics going?" So this is, the graduate students are going to tell you this distribution is exactly what you would predict by the Hardy-Weinberg theorem for a single genetic locus for high and low enzyme activity with a minor allele frequency of 5%, and that's correct. When we cloned the gene, that's what we found. So if you have low TPMT, you can't metabolize the drug, and if you use the standard PDR dose, you're going to overdose your child by about 10-fold, and the last child we saw referred here was hospitalized for 4 months with profound myelosuppression, referred here from someone outside. So if you have high TPMT, you have decreased therapeutic effect. So this is even the Mayo Medical students can understand this one, folks. So this example sort of personifies what everyone thinks pharmacogenomics is. But this is so last year, because what we do now is we put this information into the electronic medical record. We have alerts. On your right, you can see all of the drugs for which we have drug gene pair alerts in our electronic medical record. And I'm pleased to say that even in this day and age, we just brought clopidogrel or warfarin on, so I think it's going to be dethroned. It's the thiopurine alert that's fired more often than any others. Now let's move from, that's what everybody thinks pharmacogenomics is. Well, that's not what it is. That's your father's Oldsmobile. That's not the way we're doing things today. So now let's talk about genome-wide pharmacogenomics. And let's use breast cancer as an example, the #1 invasive cancer of women worldwide, about 250,000 new cases each year in the United States, and still tragically, although we're doing much better, 40,000 deaths per year. The major advance in the treatment of breast cancer in the past quarter of a century was endocrine therapy. The understanding that in the 70 to 80% of these tumors that express the estrogen receptor, that's driving the tumor growth, and if we can block that in some fashion or another, we can prevent recurrence. That is, the drugs I'm showing here, that is tamoxifen, which is an antagonist at the estrogen receptor, can decrease recurrence by 50%. And if you block estrogen synthesis with aromatase inhibitors, you get the same effect. What is not so widely understood is that you can prevent breast cancer with these drugs. And tamoxifen is approved by the FDA for the prevention of breast cancer in high-risk women. And that's what we're going to talk about, because I want us to look to the future. I don't want anyone to have to deal with the disease of breast cancer in the future. What we want to do is to prevent it. Now, the TPMT genetic polymorphism was discovered in my lab in the Guggenheim building by myself and one technician. That's the mom and pop store analogy. My dad had a hardware store in that little town in southern Kansas, and my mother did the bookkeeping, so I know about mom and pop stores. That's the mom and pop store R01 grant approach to biomedical research, which is and will remain the foundation of what we do. But you can't do the kind of stuff I'm going to talk about now in a mom and pop store. So what you see here is how this study was done. It begins with the NSABP, that's one of the NCI clinical trials group, cooperative groups, the P1 and P2 trials. The P1 and P2 trials, I'll show you in a minute, involved 33,000 women, took over a decade to perform, and in today's dollars cost over $100 million. That's where the samples came from. On your right, it says RIKEN, the RIKEN Center for Genomic Medicine in Yokohama, Japan. They did the genotyping paid for on these samples I'm going to show you for the GWAS I'm about to put on the screen, paid for by the Japanese taxpayer. I'm making the point that it takes an awful lot of people to do these studies, and it's international. And in the middle, you see PGRN. That's the Pharmacogenomics Research Network, which you heard about when I was introduced. It's a network, I'll show you a map at the end, that goes across the United States. Dan Roden's group at Vanderbilt has been a member since the beginning 15 years ago, and our group has, where we did the translational science, the statistical genomics, and the functional genomics. So this is the only small print slide. I deal with medical students. I figure that 2 or 3 words per slide is about all I can handle. So I'm sorry for the small print here, but P1 was 13,000 women, took 5 years, and you can see it reduced the occurrence, not the recurrence. These women never had breast cancer. It reduced the occurrence by 50%. P2, and it was placebo-controlled. After that, it was unethical to add a placebo to these trials, and the second trial was 20,000 women. It was raloxifene versus tamoxifen, and raloxifene did the same thing. These drugs are FDA approved for the prevention of breast cancer. So what we did was go to those 33,000 women and take the 600 women who, in spite of 5 years of tamoxifen and raloxifene therapy, developed breast cancer, and 2 controls for each of them, and a GWAS was done, genotyping across the genome, int-recon, and here you have the Manhattan plot, and in today's world we don't need to explain what the Manhattan plot is all about. And we had 2 skyscrapers sticking up here, one in a gene called ZNF423, and the other on chromosome 16, and the other circled CTSO on chromosome 4. None of you have ever heard of those genes. Now that's my point, because the drug metabolizing enzymes we knew about, they were candidate genes. We studied TPMT because we knew it metabolized thiopurine drugs. But nobody's ever heard of CTSO or ZNF423, so what do? And I'll immediately point out, because I've got a statistical geneticist coming right after me, that these were not genome-wide significant. The p-value, that is the value on the y-axis, was not 5 times 10 to the minus 8. It was about 2 times 10 to the minus 6. So Lon Cardon would say, forget it, you're doomed, you're done for. But we had looked at 60% of all the samples in the world with regard to this #1 invasive cancer of women, and we pursued this functionally. Now here's what we did. Because my colleague, Dr. Wong, has a panel of 300 lymphoblastoid cell lines, 100 from African American subjects healthy, 100 from Han Chinese American, 100 from Caucasian American, where we have all the common genotypes now. So we can pull those out of the liquid nitrogen and test them. And when we did, on the top here, you'll see the red line shows that ZNF423, if you had the wild type genotype, you could induce it with estrogens. Well, our drug is blocking the estrogen receptor, and if you had the variant, you couldn't. The SNPs are in the ZNF423 gene. But look at that, nobody's ever heard of ZNF423, but everybody who reads Time magazine, because of a famous movie star, knows what BRCA1 is, and that has some relationship to breast cancer. So if you look at the bottom, you can see that we could also induce BRCA1. Now, if you're a woman, you want your BRCA1 turned on. And this is basically saying that these SNPs, this ZNF423, turns out to be a zinc finger transcription factor that grabs onto the promoter for BRCA1, turns it on, but only in some women if they're taking tamoxifen. CTSO, exactly the same thing. So we had found 2 proteins that were involved in the induction of the expression of BRCA1, and it's been known for 15 years that BRCA1 is induced by estrogens, but it wasn't known what was doing that. It was known it wasn't the estrogen receptor directly bound to the ligand estradiol. So now we have a novel mechanism for turning on BRCA1. I won't bore you with all the gory details, but if you take the individual's homozygous for the two protective alleles, and they're shown in this table as 1.0, and compare them to individuals homozygous for both of the risk alleles, you've got a 6-fold increase in risk of breast cancer while you're taking tamoxifen compared with someone who has the protective alleles. What we're talking about, because in today's world, tamoxifen is not being used by the medical profession to prevent breast cancer because you have to treat 50 women in order to prevent 1 case of breast cancer. If we can individualize that therapy, and these drugs are not without side effects, we can now begin to talk about, to the woman in a very meaningful fashion, about what her risk is as she takes these drugs and whether she's going to be protected or not. And there are some women you wouldn't want to treat of this group, even though they're high risk. We published this paper in Cancer Discovery in July of last year. In April of last year, the United States Public Health Service Preventive Services Task Force, and in June in NICE in the United Kingdom, the pharmaceutical companies don't think NICE is so nice, recommended that all high-risk women consider tamoxifen or raloxifene prevention therapy unless there was a contraindication. So we go from one gene at a time to scanning across the genome and learning stuff that we don't already know. Now, what is this pharmacomics all about anyway? Now we're talking about another major disease, the major psychiatric disease worldwide, major depressive disorder, 16% lifetime risk in the United States. In some parts of East Asia, they'll tell you they don't have it. They have it just as much as we do, and if you really look at the data for suicide, you see that they have a major problem there too. And the class of drugs that are the standard of care for major depressive disorder are the selective serotonin reuptake inhibitors. Now, you'll allow me a personal note here. Why am I showing you a guy on the telephone? Well, on the other end of that telephone is the President of the United States. You know, the Nobel Prizes for Medicine were announced yesterday. And I thought this was entirely and poetically appropriate. Julie is being called by the President of the United States to congratulate him on discovering the neural membrane reuptake process that the SSRIs block. So I put him here, and I often tell audiences that morning I bought his champagne. I was handed a $100 bill by the head of the laboratory, and I was a fellow at the NIH then. I'd just come from Harvard, where during my residency, they paid me $3,000 a year, so I'd never seen a $100 bill. I didn't know they existed. And I drove down Wisconsin Avenue. It was before the liquor stores opened, pounding on doors saying, my boss just won the Nobel Prize, I want to buy some champagne. And one guy said, that's the most unlikely story I've ever heard, but I'll sell you the champagne anyway. I brought it back, and the cameraman from ABC, CBS, and NBC drank the champagne. He never got any of it. I had to make another run to get it. And to just prove it, look at this. I've never shown this, I think, once before publicly. So this is the picture in the NIH newsletter. And if you look right at the back door, you see a prematurely bald head sticking around the corner. So I was really there, folks. I'm not making this up. So what we're talking about now is a study that my colleague, the late David Mrazek, former chair of our Department of Psychiatry, ran here at Mayo, where he had 800 patients with major depressive disorder treated with SSRIs, and the purpose was to see if we could find any genes that related to their response to this major class of drugs. So what did we collect? Clinical outcomes, DNA for genome-wide SNPs, blood drug levels, and metabolomic data. So now we're going beyond genomics to put metabolomics into the mix. Here's the way the study was set up. Patients came in, they were seen by a Mayo psychiatrist, they were all male patients, seen by a Mayo psychiatrist, got blood samples for DNA, for baseline metabolomics, came back at 4 weeks, got another blood sample for blood drug level and metabolomics, came back at 8 weeks, same thing. So this was a controlled trial, but it was a trial not to determine whether SSRIs work. The purpose was to gather information for omic analysis. This just shows you, and I want to put this up here because every now and then I open the Sunday New York Times and it says SSRIs are a hoax, they don't work. The green that you see here is the QID score, Quick Inventory of Depressive Symptomatology. How do psychiatrists make their diagnosis? If it's breast cancer, you do a biopsy, a Mayo pathologist reads it, stains it for estrogen receptors, stains it for HER2. We know the woman has breast cancer. The psychiatrists have a series of questions they ask, which relate to sleep disorder, which relate to mood disorder, which relate to disorders in your sex life, and they give you a score, and when they do, if you get a quiz that's up here, you're depressed. The red are the same patients after they're treated. So there's a strong placebo effect here, but these drugs work. But you'll notice some of those red bars never moved. About a third of all these patients, even though they take the drug, we know that, we measure their blood drug levels, they don't have any effect at all. What is the difference? Could we begin to individualize this therapy? Well, I'm not going to show you the GWAS. We did GWAS. GWAS, every time we have done it in cancer, where we have very clean phenotypes, we found new biology. Every time GWAS has been attempted in psychiatry, with one or two notable exceptions, no one can get anything to replicate. It's not that the technology doesn't work, it's that the phenotype, that is the diagnosis, is not the same as the way we diagnose breast cancer or coronary artery disease or anything where we have an objective measure that we can quantitate. So we said, how about we add the metabolomics? Now we're going to draw blood samples and we're going to measure a whole bunch of metabolites in those blood samples. And the psychiatrist immediately say, what does that have to do with the brain anyway? What are you talking about? One guy told me, it's like looking at the sewers of Moscow to try and understand what Khrushchev is thinking. So I want to make sure you understand that I understand that. But if we can link those metabolites to genes, it's rumored that there are genes in the brain cells. So maybe it'll begin to give us hints. And what we used was a liquid chromatography electrochemical array, which focuses on metabolites that are found in monoamine neurotransmitters. And we found that one metabolite in the blood was most closely related to all of the phenotypic relationships for response to SSRIs. How much they improved their QIT score, how much they improved their Hamilton D score, and it was plasma serotonin, and we're using serotonin reuptake inhibitors. When we did a GWAS for plasma serotonin, and we had samples before drug, at 4 weeks, at 8 weeks, so what you're looking at is baseline plasma serotonin, we actually got a hit that even Lon Cardin would like. Its p-value was 7.8 times 10 to the minus 9. It's lower than 5 times 10 to the minus 8. It's genome-wide significant. How many of you, raise your hand, and I can, with the lights I can barely see anybody, but I can see your hands. How many of you have ever heard of T-span 5? Aha, I thought so. Well, if it's T-span 5, there are at least 4 others. Actually, there are 30-some T-spans. These are they're tetraspanins. They go 4 transmembrane spanning domains. Nobody's ever heard of this. I teach this kind of stuff in the medical school pharmacology course, and I've never taught anyone about T-span 5. This is something called a locozoom, where you take that scan of the whole, every chromosome, and you focus in on chromosome 4, where T-span 5 is, and what you see is all these SNPs are just upstream, 5' upstream of the T-span 5 gene. And what I'll tell you is, you can then take neurologically related cells. So we're going to make the psychiatrist happy, folks. We're going to use neuroblastoma cells, and we'll take iPS cells from our depressed patients, and we'll first take a skin biopsy, convert it to fibroblasts, make the fibroblast iPS cells, and then make the iPS cells into neurons. Did everybody hear what I said? We've actually done that. Does anybody believe that people are doing that stuff? That's what we did. Took patients who did respond, didn't respond, did skin biopsies, made iPS cells, converted the iPS cells to neurons, and now we can study neurons, and we make the psychiatrist happy. And when we use, this is just to remind you of the stuff you've forgotten from medical school. This is the way serotonin is made. It's made from the amino acid tryptophan. First, tryptophan is hydroxylated, then it's decarboxylated, and that makes serotonin. Then it's gotten rid of by MAO. It's probably bringing back very bad memories for some of the people in the audience. And so if you go to a neuroblastoma cell and knock down T-span 5, and that's the light blue, you knock down the genes that make serotonin, tryptophan hydroxylase 1 and 2, dopa decarboxylase, and you even knock down monoamine oxidase. And if you overexpress T-span 5, you get increases in all of them. So what we found is a totally novel biology. This hasn't been published yet, but I wanted to give you guys an idea about the way bringing multiple omics together may begin to help us to gain insights we couldn't have before. And as soon as we publish this, somebody's going to be out there saying, how can we use a drug to turn on or off T-span 5? And we have ideas about how this works. So we're well beyond those boring drug metabolizing enzymes. And John Black's going to get up and throw something at me because he loves cytochrome P450s. I do too. I love them. By the way, Julius Axelrod, the guy I showed you his picture, he discovered those enzymes in a JBC paper. And there are real people who do this stuff. He got his PhD when he was nearly 50 years old. He won his Nobel Prize about 12 years later. And if next time you're in DC, take the metro and get off at the George Washington stop, go up the metro stairs, turn right, and there's a big plaque with his picture on it because he earned his PhD at night school in 1 year. based on the 100 previous papers he'd written while a technician. There are some very interesting people in this business. Now, having said that, I hope I've given you so what are my objectives? To tell you we're well beyond the one gene at a time stuff, but we're implementing that in the medical records. We're scanning across the whole genome and we're finding all kinds of new drug targets and new biology we never thought about, we never heard of. That we need to bring multiple kinds of omics technologies together. Genomics is only one of them. I know Dr. Farrugia will probably throw something at me from behind the stage here. So the conclusions are, the clinical goals remain the same. I'm just a poor old internal medicine doctor. So number one, avoid adverse drug reactions. That's our responsibility. Number two, that's what we did with TPMT. Maximize drug efficacy. That's what we're trying to do with tamoxifen and with the SSRIs. And number three, for all of them, select the responsive patients right at the front end of the process. Here's the goal. We'll never get there because medicine is an art in addition to a science. We want to have the right drug at the right dose for every patient at the right time. Now, I put this map up because several people have mentioned the Pharmacogenomics Research Network. It's been going on for 15 years. I think it's done more to elevate this field and give those of us who are doing this stuff and have been doing this stuff for decades, and people like Dr. Roden and I, he doesn't like to be lumped in the same group because he doesn't want to be as old as I am. He's not as old, but almost. Have been doing this for a long, long time. This gave us access to the tools because these are very expensive tools. I showed you that one study. Just think how much it costs to actually do that study of the tamoxifen. And this is the most important slide I'll put up because these are the laboratories over on Gonda 19 where Dr. Liwei Wang, Professor Wang, and I have this unbelievable group of bright young people we work with. In the group you see right there, which is last year's group, there were 6 different languages spoken. And even this guy up here, he came from Oxford, and he said he brought a foreign language to Minnesota, English. So I don't know what he was trying to say. And I do want particularly to point to this young woman here who came from China, got her PhD at Rutgers, came here and did a fellowship, and then went to Abbott and is now at Abbott, which has changed its name. I think it's AbbVie or something like that. These are the people who are going to carry this stuff into the future and that we'll be talking about at future meetings. Thank you very much.
Thank you, Dr. Wendelbaum. I not only liked your closing photo, but I loved your photo from the newspaper. That was a great bit of evidence that you were there.
It's the only evidence I have.
A couple of really good questions coming in from our audience, and folks, don't forget you can still send a few more because they're updating here on my iPad. So certainly feel free. But maybe I was actually wondering a little bit in terms of what do you think is the timetable for being able to use pharmacogenomics to individualize drug therapy?
Well, as I mentioned several times, and as you've seen from this conference, that's happening right now. And it's not just here. Vanderbilt is doing the same thing. So that the implementation, the electronic medical record really makes this possible. Putting this information there either after the fact, if a doctor orders the test, or increasingly, it's going to be before the fact. And I sat out there yesterday and listened to all the discussion, and everyone was wringing their hands. Oh my goodness, when we start doing the sequencing and we have this information, it's going to cost a ton of money. Your germline DNA doesn't change during your lifetime. Now, I'm an old internal medicine doc, and I worked in the hypertension clinic, and I don't know how many CBCs I ordered again and again and again and again on the same patient. You order this test one time, it's there. So where are we really going to go? We can wring our hands all we want to. What's going to happen is, and it's going to happen beginning next May, here John Black will have an Exome Plus, and he'll capture all of the coding regions of all of the genes and capture areas also that are important outside of the coding areas for these drug metabolism genes, and it won't be 9 or 10 genes. Right now, we have a panel of about 9 genes. And what I will tell you, because I heard the question, well, who does this apply to? Everybody. There's not a single person in this room who doesn't have many variations in their drug response genes. These are not rare variants. We're not talking about rare genetic disorders. Every single one of you, by the time you get up to 5 genes, and Dr. Roden may show some of the data from Vanderbilt, you cover everybody. So this comes right home. This is the area of genomics that's going to come home to rest with every single patient at every single medical center. And it will be preemptive. It won't be somebody checking a box and waiting 2 weeks to get it back. That's where we're going, and what we're going to be doing here, that's the royal we, I don't do any of the work. John Black will be doing that in the clinical laboratories because it makes so much sense. Now that creates all kinds of interesting economic and ethical issues. And we've talked about some of those, but that's happened, that's gonna happen. So let's don't sit around and say, is that going to happen? It's here, it's here.
So when you say create some interesting economic issues, I would think, again, picking up on yesterday's conversation, there'd be the question of who will pay for this?
Yeah, right now, nobody. But that's okay, that's the way every technical advance. I remember when Mayo put in its first CT scanner. We were wringing our hands in. Oh, will anybody use this fancy technology? And it will. What's going to happen is somebody will come up with a way to make that economical, and we'll study what we do. We need to study what we do and say what the implications are. Do I have any doubt at all that having every doctor, without even having to think about it, I mean, who can carry Goodman and Gilman around in their head? Only somebody like me, and even I can't do that. So guys and gals, what we're going to do is it will be there. It will be easy for you. It will already be available. So do I have any doubt that this is going to be economically viable, and one of these bright young people will come up with a way to get your whole genome for $50 before we're done. But we're not there yet. But that's what's going. So we better not be talking about the past century, the time that I was doing this stuff. We should be talking about this century and the kind of medicine that all of us, including my daughter at Wake Forest, will be practicing sooner than we think. It may come across that I'm a fairly enthusiastic type person, but I have been behind the wave at every step along the way, mainly because of really smart young people who pay no attention at all to what we say can't be done, and they just go do it.
That's absolutely. Here's a good practical one, I think, from our audience, Doctor. Considering the challenges in implementing drug gene rules at Mayo, how do we make it easier for small practices? Some advice?
No, and it is hard. Did I, a kind of lab wonk, I said, well, gee, we have an electronic medical record, just go put them in. And a whole team that John Black led on our pharmacogenomics task force demonstrated every time I'd go to one of their meetings just how difficult that is. So it's extremely difficult. But I think as we move into the Post-Affordable Care Act era, where every practice has to have an electronic medical record, that this will eventually have to become an integrated part of every electronic medical record. So that's going to come, but please don't think that I underestimate or fail to understand the challenges. They're very real, and this is not easy. This is really hard.
And it certainly is coming through to me in your comments and others yesterday, the importance of the electronic medical record and that it be fully interoperable.
Yes, which my daughter occasionally calls me up and is cursing about their electronic record at Wake Forest. And we've had a few of those. So do we understand that there's a long way to go before it really is making your life easier the way it's supposed to? Yes.
Yes. Another good one from the audience. Do you think there is utility today in doing predictive pharmacogenomic?
Well, I just said so. Yes.
Yes.
And so what we have to do is find a way to make that affordable. And look, it's places like this place where we have outstanding people like John Black, who's visionary and says, we're not just going to genotype, in other words, keep repeating what we already know, but we're going to sequence, so we'll find all kinds of variants of unknown significance. Of course we will. You don't go into medicine if you can't deal with uncertainty. I mean, this is not some place where you know the answers to everything. But what we'll have then is hopefully machine learning that will begin to teach us which of those new things we're going to find really have some importance. that have clinical utility. Obviously, the point is not to bother either the physician or the patient with things that don't have clinical utility. But there is a discovery side to this, and that was the point I was trying to make when I was pointing out we've gone across the genome, we're putting multiple omics together, because that's what will move us forward and give us the information. Think how much, I showed you those data about ALL. I was telling the truth. I remember my peds rotations in medical school at the University of Kansas. Those kids were all dead within a year. What we're able to do and what St. Jude is able to do are a miracle. And for those parents, they expect that. And when my daughter called me one day, she makes rounds and then she calls me when going back to the office. And doctor fathers enjoy that far too much. And she was telling me about going to a birthday party for a 13-year-old where she diagnosed his ALL when he was 4. And he was having his 13th birthday. Inconceivable when I was in medical school.
But let me pick up here. You are very passionate and you have this wonderful vision for the future when this will be...
The future is not just around the corner.
Okay, but let me ask you, on that journey to where you're taking us, can we prioritize who to start with or what to start with?
Well, in pharmacogenomics, that's why because I heard this discussion, I actually sat back there and was taking notes. You know, who does this really apply to? This is one area of genomics where it applies to you, your wife, your kids, your grandchildren, to everybody, because these are common genetic variants. And you don't know what drug you're going to be exposed to. We can predict that virtually all of us will be taking a statin someday, and clopidogrel for a lot of us. But the fact of the matter is, these are, in my mind, demonstration projects to get the point across. Because everything you've seen up until now is on the pharmacokinetic side. It's that boring drug metabolism stuff that I've been teaching the medical students and graduate students all these years. What I was trying to point out was we can now move over to the pharmacodynamic side from the pharmacokinetic. What happens when the drug actually hits the target? That's what I was showing with tamoxifen. It hits the target and strange things happen to BRCA1. What happens with regard to the SSRIs? Something's going on with this T-SPAN5 that none of you and I had never heard of until just a few months ago. So that I think what I can say is that for pharmacogenomics, it's a matter of demonstrating clinical utility and then gradually adding all of that information. But we know where to start. It's that boring drug metabolism, drug transporter stuff.
I wanted to go back to your presentation for a minute. You had the breast cancer example there. How might that be applied in clinics?
If that can, now notice I'm being careful here, if that can be replicated, what that might do is give us the ability to have a meaningful conversation with the woman about the fact that even though these drugs have side effects, she is one of the women who's uniquely going to respond and will benefit. I mean, some of those women appear to have a deficiency of tamoxifen. Now, I'm being facetious, of course, but they really respond very well. Other women, we may actually be putting them at greater risk. So I can see the day, and I work with, all of the breast cancer work that we do is done with Jim Engel and Matt Getz from our breast oncology group. I can see the day that they'll have a heart-to-heart conversation with the women they're seeing who have a family history and be able to actually give them good data about what the risks and the benefits might be, and that's the hope.
One final one from our audience, and this has to do with the regulation of lab-developed tests by the FDA. How do you think that might affect cost and quality?
I am the worst person in the world to ask about clinical laboratory lab-developed tests, but you're going to have Larry Lesko up here in a few minutes, who spent most of his career at the FDA, and I say let's ask him that question.
Let's ask Larry. Okay, so somebody in this room better remind me that we ask Larry that FDA question. So then we'll close with my final question, which is, you've got this wonderful audience, many students, many clinicians from all over the world here in this room today. What would be your advice to them?
Well, I wouldn't deign to give anybody any advice, but I can tell you I envy all of you, because you're entering a world of medicine that when I was in medical school was inconceivable, and it's because of the kind of people I showed on the last slide. Thanks.
Wonderful. Thank you, Doctor.